Hello, and welcome to our training on understanding bipolar 1 with psychotic features. This is a part of our series on understanding serious mental illness as part of the CARE Act training and technical assistance. Let's go ahead and look at our learning objectives today. So the goal is that by the end of the session, you will have a better ability to describe the clinical features, diagnostic criteria, and the treatment of bipolar 1 with psychotic features, and also outline some ways in which county behavioral health teams can adapt to support these individuals under care. So today we're going to have a few different sections. We're going to go over bipolar 1 and CARE Act eligibility, then talk about some of the diagnosis and clinical features, talk about some treatment recommendations, and then how we can incorporate these individuals into care processes at the county level. Today's presentation is going to be shared by Laura Collins, and Laura Collins is a licensed clinical social worker with 25 years of experience in psychiatry across the behavioral health continuum. This content was informed by Dr. Kate Warburton with the Department of State Hospital, the California Department of State Hospitals, and she's an associate professor on the volunteer clinical faculty within the UC Davis Division of Psychiatry and the Law. So with that introduction, I'll turn it over to my colleague, Laura.
Thank you, Patricia. Hello, everybody. Let's begin with a brief discussion of the addition of bipolar 1 disorder as that care-eligible diagnosis. So the changes in Senate Bill 27 include an expansion of the diagnostic criteria for CARE Act. Originally, CARE Act eligibility required a diagnosis of schizophrenia spectrum and other psychotic disorders. However, SB 27 has added bipolar 1 with psychotic features as an eligible diagnosis, and that'll be effective January 2026. So it is important to note that according to the DSM 5, a TR, a fairly small percentage of adults, about 1.5% in the US, have been diagnosed with bipolar 1 disorder in the last year. And among these individuals, there's even a smaller subset with psychotic features that take place during extreme mood episodes. So, in addition to the fact that eligibility for care is not just limited to diagnosis, but must also include functional and safety criteria for access to care. So, it's really important to know that there's additional criteria there in addition to the diagnostic component. And let's move to the next topic here. So it is interesting to note that bipolar 1 disorder with psychotic features does share substantial symptom overlap with schizoaffective disorder, bipolar type, which of course is already a care-eligible diagnosis. As this disorder also includes the presence of mood episodes accompanied by psychosis. So including bipolar 1 with psychotic features as an eligible diagnosis can help promote equitable access for these individuals that have comparable clinical profiles to existing care respondents. And thinking about the next topic here, as I briefly mentioned earlier, remember that eligibility for care does include additional criteria regarding the person's current engagement in treatment, level of functional impairment, and certain safety and risk criteria. So again, having an eligible diagnosis is not sufficient on its own for acceptance into care. Since not all individuals with bipolar disorder will meet these other care criteria, there are still other less restrictive alternatives available to individuals with this diagnosis outside of care. And then thinking about this diagnosis further, let's consider a fictional case to help us apply some of this new information regarding care eligibility. So we're going to meet and talk about Jordan. I'll give you a quick background on him. He is 45. He was diagnosed with bipolar 1 disorder in his early 20s after a hospitalization. He had mania during that hospitalization and some grandiose delusions, impulsive behavior. And over the years, he continued to experience several mood episodes, both manic and depressive, and some psychosis during that time. He had a period of functionality where he was in a trade school and then dropped out, really related to his illness. And he's having trouble with current employment, partly related to not getting treatment for this disorder. And he's having inconsistent engagement overall with his outpatient care. He even recently was arrested for trespassing. And most recently, he did have delusional symptoms of paranoia and was brought to the emergency department after a public disturbance. And he really hasn't been engaged in voluntary treatment at this time, and he had discontinued his medications several months ago. So we really want to think about what to consider for Jordan. Um, and he had historically been considered for care. He had been even petitioned on for care, but because of his diagnosis of bipolar 1 at the time was not found eligible, was not an eligible diagnosis, the case was dismissed. So right now the county behavioral health team is outreaching him and reconsidering him for getting those services and supports through care. So that's Jordan. And let's move to some ideas in action. And we want to think about what the county behavioral team might consider as next steps for Jordan, giving the updates with bipolar 1 with psychotic features as an eligible diagnosis. And so, of course, I think what they want to consider is they were aware of his diagnosis and that the only primary reason that the case was dismissed was because of that non-eligible diagnosis. So, of course, thinking about how to outreach, how to re-engage Jordan into treatment via the care process would be the first step, and just kind of doing that reassessment in terms of eligibility. All right, so moving to our next section, which we're going to talk a little bit more about this diagnosis and its clinical features. And thinking about the classification and diagnostic criteria here, starting with that. So the one big call out here with bipolar 1 disorder, it is classified as a mood disorder versus the prior eligible or the current eligible diagnoses, schizophrenia, spectrum disorder, and other psychotic features. Those are classified as psychotic disorders. So bipolar disorder is really primarily characterized by episodes of mania, depression, and sometimes both simultaneously, which is often referred to as a mixed episode. And according to the DSM, the Diagnostic and Statistical Manual of Mental Disorders, a diagnosis of bipolar 1 disorder requires at least one manic episode in the individual's lifetime. And importantly, symptoms of this disorder, including the mood disturbance, must cause significant impairment in functioning or require hospitalization. The psychotic features component. So with bipolar 1 disorder, psychotic symptoms can occur, but they emerge generally during extreme mood episodes. So that would be during an acute manic phase or a major depressive episode, and typically resolve when the mood episode resolves. So in between mood episodes, individuals typically don't experience persistent hallucinations or delusions or, psychotic symptoms. So this really does contrast with schizophrenia and particular schizoaffective disorder, which are conditions that are characterized by a combination of mood disorder symptoms such as depression or mania and persistent psychotic symptoms, where the psychosis is really the defining nature and can be continuous. So it's really important to note that the mood symptoms of bipolar 1 tend to be more responsive to treatment in comparison to the primary psychotic symptoms of schizophrenia or schizoaffective disorder. And many folks who experience psychosis during that manic or depressive episode can achieve a full remission of their psychotic symptoms with the proper treatment. And they can remain stable and functional in the community without that need for intensive ongoing wraparound services. So next, let's think about some of the common symptoms we may see that are experienced and exhibited by individuals with bipolar 1 disorder with psychosis. So during a manic episode of bipolar 1, individuals may exhibit an abnormally elevated, expansive, or irritable mood, along with that increased energy and activity. Manic episodes can involve a lot of symptoms, and a lot of them are displayed here on the slide. Really want to highlight that grandiosity, the decreased need for sleep, pressured speech, racing thoughts, psychomotor agitation, fidgeting, pacing, and a big one is impulsivity. So typically putting themselves in a risky or a dangerous situation. And these mood disturbances during manic episodes are typically severe enough to cause what we call marked impairment in social or occupational functioning. And it's typically accompanied by psychotic features during that acute phase. So it's also important to call out that depressive episodes can also occur in bipolar 1 disorder, which, in addition to having that depressed mood, may also come with some very serious symptoms that are listed on the slide. Um, Really notable is also some sleep disturbance, low energy appetite, lack of pleasure and interest, lack of hope is not on the slide, but a big one. And then calling out suicidal thoughts. That can be a common symptom in depression and bipolar 1 and can occur during a mixed episode where the individual is experiencing mania and depression at that same time, which often is tied with irritability and agitation. So let's think about ideas in action here and how the diagnosis and clinical features described that we just described apply to Jordan and his situation. So when I described Jordan, I talked a lot about that long history of bipolar disorder that where he was really intermittently accepting treatment or seeking out treatment, and he was definitely displaying the symptoms that we've just covered. Um, so this calls out the fact that he may be in a place where he could benefit from that extra touch in terms of outreach and engagement to engage him in temporary more wraparound services um, and treatment for this disorder, which may be in an acute phase right now. And moving to our next section where we talk about the time course, the risks, the common long-term outcomes for persons experiencing this particular disorder, thinking about that onset and clinical features of bipolar 1. So starting with that, which the onset does typically occur in late adolescence or early childhood, or early adulthood, excuse me. Bipolar 1 disorder also tends to be episodic or cyclical in its course. And a typical pattern involves recurrent manic or depressive episodes over time, with periods of full or partial remission in between. An untreated manic episode can range in duration from weeks to months, and most individuals with bipolar 1 will experience multiple episodes of mania, depression, or again, mixed in their lifetime. But really, not everyone has that regular cycle. Some may have long, stable intervals, while others may have more frequent relapses or episodes. Okay, so when psychotic symptoms are present in bipolar 1, they typically occur during the height of mania or during a severe depression and generally resolve when the person's mood stabilizes. The intermittent nature means that persons with bipolar 1 disorder can often regain baseline functioning between those episodes if they're effectively treated. So, in contrast, and as I've mentioned, but important to restate, individuals with schizoaffective disorder may continue to have some ongoing psychotic symptoms even during periods of stability. As schizophrenia spectrum disorders typically include chronic or enduring psychotic symptoms that really aren't contingent on mood, whereas a person with bipolar 1, once stabilized, may not exhibit any psychosis or any major functional deficits for long periods. Individuals with bipolar 1 disorder usually have a lower incidence of what is known as anosognosia, or a lack of awareness or insight into their illness. This is in comparison to individuals with schizophrenia. And many individuals with bipolar 1 recognize changes in their mood or reality testing, especially once that acute episode passes. As a result, they may be more amenable to engaging in voluntary treatment. And mood stabilizing medications can often prevent manic episodes from escalating to that more acute or severe state, and can in turn reduce that likelihood of psychosis, and really, again, supports individuals in maintaining that independent living, that high functionality and employment. And many persons are really able to return to that level of high functioning, maintaining their relationships, their employment, their community roles. So let's think about some of the risks associated with untreated bipolar disorder. So bipolar 1 disorder does come with significant risk, particularly if it's not adequately treated. So the slide really speaks to how it does elevate the risk of suicide, both in the manic or depressive phases, especially if the manic and depressed phase is a mixed episode as well. But significantly, there's a significant risk with depressive episodes driving that suicidal ideation. And then in terms of consequences, during mania, individuals can engage in very high risk behaviors. Their judgment is impaired, their inhibitions are also impaired. And so that can place them at physical, financial, social risk. And also personal and social disruptions can occur with untreated bipolar disorder. Again, just can't, and this truly can have an impact on a person's life long term, depending on the decisions that they make. The other thing to call out is there is a higher risk of comorbidity of substance use disorders with bipolar 1 disorder, as with some of the other mental illness, serious mental illnesses. And substance use can further destabilize an individual's mood and again heighten that risk of adverse outcomes. So let's move from risks associated with untreated bipolar to the positive long-term impacts associated with accessing the treatment and supports. So we understand that both early and sustained interventions with mood stabilizing medication can greatly reduce the frequency and severity of mood episodes, which in turn can lower the risk of hospitalization, lower the risk of suicide, and lower the risk of overall psychosocial decline. So accessing both psychotherapy and maybe even temporarily some case management, but also community supports can improve medication adherence and help with improvement in coping skills, and again, leading to that better functional recovery. And in many cases, bipolar disorder with psychosis can be managed to the point that individuals have only rare relapses and can lead a life of sustained recovery. So thinking about moving to ideas in action, I'm thinking about Jordan and his history, his current challenges, and the question really is, how do these reflect the typical course and the risk associated with bipolar 1 psychotic features? Well, definitely we've seen Jordan, as an example of someone who has had these risks. He's been arrested. He's been hospitalized. He's now unemployed. So definitely, he's experienced those risks based on not accessing treatment regularly. So let's move to our treatment recommendations. So treatment of bipolar 1 with psychosis really should be guided by evidence-based practices. The APA, American Psychiatric Association, does outline these and really highlights the importance of a patient-centered approach, that they're crafted in collaboration with the individual, that they're respecting that individual's goals, their cultural background, and are comprehensive. So they're addressing the whole person, medical, psychiatric, and their social needs. And let's quickly also talk about pharmacotherapy. So mood stabilizing medications or mood stabilizers, you'll hear them called, can reduce manic symptoms. They can prevent suicide, of course, and provide long-term mood stabilization. The presence of psychotic features often necessitates the use of antipsychotic medications. So in some cases, an antipsychotic on its own can manage a manic episode, but combination therapy is often indicated for severe episodes. So antipsychotics are usually tapered down after the acute phase, if possible, with the mood stabilizer continued as maintenance for the individual. Several psychosocial treatments can improve outcomes in bipolar 1 disorder. So, the evidence-based modalities for bipolar disorder include, and these are just naming a couple of them, cognitive behavioral therapy can truly help individuals identify and manage their triggers for mood swings. They can help challenge those, identify and challenge those dysfunctional thoughts or cognitive distortions. Family psychoeducation or family focus therapy is really about educating the family members on mental illness, communication and problem solving skills, warning signs of relapse, and then the importance of adherence to treatment. But treatment guidelines also encourage and support groups, peer support, and rehabilitative services when indicated, like supportive employment, supportive housing, um, again, bringing in a little bit of that wraparound support. And as I'd mentioned earlier, case management is also a good interim treatment for individuals or intervention for individuals, especially in their acute phase, which again could apply to someone in care, the CARE Act. So next, let's talk about lifestyle interventions. They're really an important part of that holistic treatment plan. So thinking about regular sleep-wake cycles, that's very important with this particular disorder. Sleep deprivation can actually trigger an episode of mania. So individuals are often advised to also minimize their alcohol or drug use. Substances, again, as I'd mentioned earlier, can really destabilize the mood, can interact with medications. Managing stress through techniques such as mindfulness or regular exercise, of course, can help maintain stability and, again, help the whole person as well. And of course, the interventions, again, should follow that person-centered, trauma-informed, collaborative, motivational interviewing approach. And just, to be sure that they're aligned with the individual's priorities. What are their goals? What are their cultural beliefs? What are their life circumstances? So let's move to that ideas and action. So what treatment options might be a good fit for Jordan? So, of course, we want to think about the pharmacotherapy. So we want to think about, talking to them about getting started on a mood stabilizer, potentially an antipsychotic medication, depending on the psychiatrist or prescriber's recommendations, in collaboration with him. Psychosocial interventions. It might be a little early for cognitive behavioral therapy for him. It might be a more case management approach and bringing in CBT, bringing in the family if they're in the picture. with that family psychoeducation. And then, of course, thinking about uh, part of that case management can be really working with him around getting regular sleep if he's able to, and minimizing substance use and stress management strategies. And let's move to thinking about county behavioral health and how the teams with the county can adapt now that individuals with bipolar 1 disorder with psychotic features are now eligible under care. So, what kind of adjustments or expansion to their practices do we want to think about for them? All right, so here are some ways that care teams can help um, prepare for working with these individuals. So training is key. Not only, ensure that teams are trained in the unique features of bipolar 1 disorder with psychosis, but understanding how to assess for that diagnosis depending on the team member, understanding what the unique treatment recommendations might be, and understanding that recovery trajectory, where we talked about that really great response to medications and treatment that these individuals with this disorder have. And obviously, we do want to encourage an expansion of the screening tools so that everyone is aware that this is now an eligible diagnosis when you are screening for care. Um, in addition to that training, you want to make sure that any team member that already is that you're bringing on, or contractor providers you're bringing on, understand working with these individuals as well, and the interventions that are evidence-based. The most important thing I want to emphasize on this slide, though, is really revisiting those individuals that may have already been referred to or petitioned on for care, and their case was dismissed simply because of the diagnosis. So you want to think about who can we revisit, and if this program would still benefit them, re-petitioning, re-referring them for care to see if they can access these services and supports through this structured process and system. And next, let's think about some additional recommendations for care teams to consider, when they're thinking about their clinical planning, their service delivery. And again, as I mentioned, make sure your teams are really equipped to address the symptoms of bipolar 1 disorder. And then again, tailor the services as their unique needs change. Again, you want to think about integrating different therapies, not only that are proven for effective for bipolar 1 disorder, but unique to that individual, and thinking about incorporating additional services into that care agreement or into that care plan. You want to talk about the sleep-wake cycles, managing substance use, stress levels. Let's think about also incorporating that, thinking about any rapid interventions you want to incorporate related to manic or depressive episodes, especially suicide risk assessments, managing impulsive behaviors. And these are things that you could include into a psychiatric advance directive as well, when you're thinking about safety plans for these individuals. And that again are addressing those high risk activities. And part of developing a psychiatric advance directive is incorporating peer support into the team, not only to inform the work with the individual, really promote strong engagement with that person with lived experience, but again, help support them in development of their psychiatric advance directive. They're also very effective in psychoeducation as well. And let's go to our next and our last ideas and actions. So let's think about how county teams can adapt for Jordan. Coming back to Jordan here, and what we want to think about for him. Again, I think the priority would be, as we know, Jordan's case was dismissed. So he already was flagged for the county as someone who could benefit from care. So the first thing they want to think about is revisiting um, getting him back into care. So definitely proactively outreaching and engaging him, and then really using that training, assessing closely, and really providing that unique treatment plan for Jordan that can hopefully change that cycle of going in and out of treatment to maintaining engagement with the team and having that great stable trajectory as he engages with the team and goes through the CARE Act process. And I'm going to hand it back to my colleague Patricia to revisit our objectives for today. Patricia?
Thanks, Laura. So, as Laura talked through some things to consider for bipolar 1 disorder with psychotic features, the goal is that you would have had an increased ability to describe those clinical features, some of the diagnostic criteria, and treatment recommendations for these individuals. And then also outline how county behavioral health teams can adapt to support these folks who are now eligible under care with this additional eligible diagnosis. All the slides, including the talking points, are included on our website. So if there's more information that you're looking for, you can go ahead and go there. You are also welcome to visit our website, look for other additional training and technical assistance resources, including trainings, briefs, FAQs, toolkits. And if you are looking for a resource, if you have a question, please feel free to send an email to info@careact.org. Thanks.